Hello, everyone. Good morning, good afternoon, and good evening, especially those from Cambodia. I'm William Gali. I'm from the Secretariat, Family for Every Child Secretariat. I'm one of the senior program advisors. All of you are very welcome to this evening's webinar. This is the continuation of the last one we had. The session 2 is about trauma-informed approaches in practice. And today in specific, we are going to hear from Shamron from First Step Cambodia. Um, First Step Cambodia is one of the member organizations of Family for Every Child. And this webinar is hosted through the Mental Health and Emotional Wellbeing Community of Practice. And special welcome to all of you who are members of the practice already, and welcoming others to join this community of practice. Just for those of you who are not familiar with Family for Every Child, without taking much time, Family for Every Child is a global alliance of 57 members in 42 countries. And we have about 8,000 community of practitioners through the Change Makers for Children. We are child rights focused organization, believing in evidence rooted in local solutions and knowledge. A lot of work is through dissemination and influencing, through advocacy campaign. The impact points are through policy and practice largely. Impact strategic priority is strengthening and building the resilience of families for children to grow and thrive. And we have mental health as a cross-cutting theme. So this is the community of practice, which we recently started. So the whole idea, the goal is shared purpose, learn from each other, and practice focus. We are really trying to encourage peer learning and not really capacity building or training. So this platform serves as sharing our purpose, learning from each other, and it is purely a practiced focused platform. And this is done through sharing experiences. We learn across contexts, not only just through our members in our member countries, but others who are through the change makers. And we exchange tools and practice manuals through the community. And again, it's largely a reflection on practice. And of course, a very good platform to build connections. So we're turning experience into insight, like example of today's, we're going to learn from Cambodia and see what insights we have from their practice. For those of you who are joining, we will also have later a link in the chat. If you want to join the community of practice, please join us. All of you are welcome, members of Family for Every Child and those who are not, including individuals and practitioners. Just a quick recap on what happened the previous time. We had our member Beatrice and Mafe from ABTH, that is Association from Brazil of Terra-des-Hommes. The short form in English is, this is different. This is in Portuguese. They shared about their experiences from working with young people through Voces de Alma, the Voices of the Soul. That's their program. It was very exciting, especially listening to their stories of change. So the key learnings from that sharing was starting with what young people already value rather than with professional frameworks. So the whole thing was built from the young people and their experiences, and quite a very strong participation model. And then the importance of building safety before going deeper, a very strong trauma-informed care principle, building safety, and then how collective action can achieve things individual support cannot. I think both the speakers were very strong about a collective approach, especially from their communities. So today, I'm going to just give a little brief to set the context, just a note on what trauma-informed care, because we will in the future have more members sharing their approaches based on trauma-informed care. And then the actual presentation for today, the highlight is the approach that First Step Cambodia is using. And we have Shambron, the right person who has been there from the beginning of the organization now, who's the executive director. And then after the presentation, we'll have a little bit of a Q&A, again focused on what learning you want to carry to your organization and what insight you got rather than really um, questions. Of course, if you have questions for clarifications, that will be nice. Shamron will be very happy to answer and clarify. So just to set the context, I thought it was important since there's so much talk about trauma-informed care. Just a couple of slides. Um, Trauma-informed care is not a service type or outcome. It is an approach, it's a way of working. It means that services are delivered with awareness that many people have experienced trauma, and therefore it prioritizes physical and emotional safety, trust and transparency, choice and collaboration, avoidance of re traumatization. I think this will be a little more important slide for us. The difference between trauma informed and trauma focused care. Uh, we, at the moment, the Family for Every Child, many members use trauma informed approaches. So, trauma informed care is a way of providing all services through a trauma sensitive lens. Whereas trauma focused care, specific therapeutic interventions that directly treat trauma or PTSD. Trauma informed care focuses on how we work with people. So it's about the process, and trauma focused focuses on what we treat, the trauma itself. The trauma informed care can be used by all professionals, yeah, teachers at school context, or social workers, health workers, NGOs, leaders, whereas trauma focused care requires specialized clinical training and competence. Now, the goal for trauma informed care: create safety and avoid re-traumatization. I think this is these two are like really critically key goals: creating safety and avoiding re-traumatization. Whereas the goal for trauma-focused care is process and heal traumatic memories and symptoms. So, as a conclusion to this, we can say that every trauma-focused intervention should be trauma-informed, but not every trauma-informed services needs to be trauma-focused. Although there is quite a lot of discussion about how even trauma-focused intervention do not have trauma-informed knowledge or context. That's not discussion for today, but um, for us practitioners who are using trauma-informed care, uh, all trauma-focused interventions should be trauma-informed, and we'll just quickly look at the key principles. This is the last slides on the context, the trauma-informed care. Just for us to know, not just for this presentation, but for any of us working in trauma-informed care, safety is the first principle, creating physical, emotional, and psychological safety. And second principle, trustworthiness and transparency, being very honest, predictable, and building trust. Peer support, which is valued very much. Value healing through shared lived experiences. It is, I think, really they're building from bottom up. Collaboration and mutuality, that is working with the people, not on them, and reduce power differences. Empowerment, voice, and choice, recognize trends and give people control over decisions, over their life experiences, over what they have, and to own them. And then this is also important, especially for us organizations like network organizations or organizations working in diverse contexts and situations. Cultural, historical, and gender responsiveness. So we're respecting culture, identity, history, and at all costs avoiding any discrimination. So this is just for those of you who like image again. So the principles are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and culture, historical and gender issues. Now we come to today. The man of the show is Shamran today. And we are very happy that Shamran, in spite of his busy schedules, has been recently a lot in the field. He's able to be with us and share his experience. So I was just saying that Shamran has over 20 years of experience in Cambodia's social sector, providing mental health, social welfare, and social protection services to vulnerable communities. He has been involved with First Step since 2010 and has served as its executive director since 2012, leading organizations, operations, and staff team.
Good morning, good afternoon, and good evening, everyone. And so let me begin with introducing First Step a bit. So First Step established in 2010 and legally registered at the Ministry of Interior in 2012. So we have 5 programs. We focus on our work on prevention, direct support, capacity building, advocacy, and research. And our vision, what we want to see is every child enjoy a safe and nurturing environment. And we work in partnership, so we don't work alone. We ensure that we strengthen inclusive child protection system that empower children to live safely and free from all forms of abuse. We engage and we advocate for boys, and we also work with boys to challenge harmful social norms. So our prevention program, mainly we focus on empowering children and youth to become change makers in their communities, as well as we engage with parents, legal duty bearer. So we empower them with knowledge and skill to prevent sexual abuse and to strengthen the community child protection. Our support program, which I'm going to talk about in a minute, we focus on providing therapeutic and social support to children who are survivors of sexual abuse. So children here, we focus on both boys and girls, and children with disability, also children who are identified as diverse GSC. We also provide services to children who are displaying or who display harmful sexual behavior. And with these services, we don't just focus on individual, we also focus on strengthening their family, building the capacity of their caregivers, and linking them with the community resources. At First Step, we also believe that it's important to have a strong social service workforce to ensure that children are safe, protected, and receive comprehensive services. So we provided a lot of capacity building to social workers, counselors from NGOs and government. And we also focus on advocacy because we understand that we can do like a very comprehensive work on the ground, but if the national policy legislation doesn't really support such initiative and work, it doesn't sustain, and also it doesn't really optimize the impact of the work. And we understand the lack of research and evidence in the area of child protections and abuse, children who display problematic and harmful sexual behavior. Therefore, at first step, we also focus on documentation of our practice, but also conducting primary research. So at first step, our support program, we adopted the ecological model approach to support children. So in our support services, we don't just focus on individual, we focus on different level that influence individual. So on the individual level, we focus on the children, and we customize our services to meet the different needs of the children. We don't just design the services and to using like the one size fit all for all children. So our social workers, we focus so much on relationship building, building trust, and making sure that the children experience safe and positive relationship with our social workers. And in the session, we empower children to participate, to lead the session, ensuring that they feel that they are the focus, they are the person who own the support or the session. So at the next slide, I will show you how we engage, we build trust with the children. And our assessment framework, we actually adopted the child status index to conduct our assessment. So each of the child, we also try to understand their nutrition, their food, their shelter, cares, and health, and child protection, legal support. Many of the children in Cambodia, they don't have, like legal document like birth certificate, family books. So often they don't have access to the public services. So beside the children, we also focus on their relationship. So our family strengthening model, we try to understand what the relationship within the family look like, if the parents are able to support the children, if they have time for their children. So we also work closely with the primary caregiver of the child to help him or her feel supported along the way, understood, and also that throughout the process, we build their capacity around, coping skill, positive parenting skill, and if they need any, support for income generation, legal assistance, health, we link them to the existing service provided by government, by other NGO in the community. So within our assessment framework, we also prioritize looking at the existing community resources that we can mobilize to help the child and the family. So alongside, we also try to advocate for improved policy legislation. At the same time, we look at how the existing policy and resources can support this child and this family. And in many cases, we may need to get the commune budget to support some of the family if they need it. So in terms of our individual session with children, with family, at first step, we understand that children don't really engage or struggle to engage in, long sessions, like long traditional conversation. So we adopted a lot of art and play to help children and our staff to be relationship with children, help them talk about their problem, about their experience, about like something that is very hard. For example, when children experience abuse, it's very hard for them to express in word. So we use the body map to help children, they to paint different color, different part of their body, and then they can start talking about it. Some children prefer not drawing or painting. They prefer playing with, like dolls that customize in different person. And other may prefer to use puppet. So they talk to our social worker using the puppet that they chose. Other may prefer to use drawing, and we also use different card like flower card, cloud card to help children identify problems and explore different solutions. And in terms of family relationship, we also adopted the genogram that children can play, but then it helps them understand what their relationship look like within the family and identify their support system, who they can go to when they have problem. And other may choose to play ball, just throwing, passing ball, and asking questions and talking about different game that they engage in school, that they engage, that they play with their family. And the goal is to have children, uh, recover. So recover here is around helping them to express about their problem, their feelings, and then they learn how they can manage some challenging feelings, and then linking them to their daily life so that they can, uh, get back and go back to school. So at first step, our practice is a bit different, and we don't usually set like a limit to our session, or sometimes I learned that in some counselor that they set only 10 sessions and so on, but at first step we do not have such thing. And also our support period often lasts between like 16 to 24 months, or sometimes even longer, depending on the child situation, depending on the family situation that we work with. And at first step we also believe that the best place for children is their family. That's why family strengthening is one of our core focus, and system linkage, linking the family to the existing resource within the community, is also one of our priority. And I would like to share some of the story that of the children we supported. This is the quotation from one of the boy with disability who live in a residential care center, who actually didn't understand about sexual behavior, and then he end up having the harmful sexual behavior toward other younger boys who live in the same residential care. So actually, after we work with the boy and their primary caregivers, he actually appreciate the fact that learning about respect and boundary is very important for him. His life was already very challenging, and with the behavior, and he actually experienced even more discrimination. So after the support we provided, he changed the behavior. He actually committed to, help other understand what is, like healthy sexual behavior and what is problematic and harmful sexual behavior. This is another case of a girl, a young girl, who actually experienced sexual abuse from a very young age. And then later she become almost a person who care for the family. And during the COVID-19, it was very hard time. Her mother was very ill, and they hardly have any food. And our social workers support has been very, very important during that time. And what she said, without your support, my family or my father would die. And you know this is one of the incident, but then later on with the support session, at the further support session, she gained confidence, she returned to school, and then she started having hope again, because at some point in her life she was thinking about her life is going to be end up living on the street or jobless. Then this is another example of a foster care father of an NGO partners in Cambodia, who actually adopted or foster a daughter who actually has been, like placed in different residential care centers for a period of time. So she didn't have really healthy relationship or didn't develop, like a healthy attachment. Then she ended up develop some sexualized behavior toward herself, but then also sharing inappropriate pictures and video of herself with others. And then with the support of our social workers, she actually stopped the behavior, but alongside we support the foster father to also understand that what he has been doing was not helpful. And that's how he appreciates the support we provided. So I want to end my presentation here and give you some time for question.
Thank you, Shamron. That was very precise, short, sweet. You really tried to sum up that so clearly, so much that you're doing. Before I just like to, if you stop sharing, then I will share this slide. We had, since this is a community of practice, we are not just only talking about the practice that was shared by Shambran just now, but we are also looking to listen to others who have similar experiences, um, practices that you are using, and your challenges and the opportunities that we have in this area of work. So maybe first we just take quickly a couple of questions, and then we will come to this. Thank you for those who joined a bit afterwards. All of you are welcome. If you have anything to ask Shamron for any further clarification, etc., please let us know. You can unmute yourself, and while we are waiting for your questions, clarifications, we had one which actually we thought probably time may not be enough, so Shamron really made it short. We really wanted to ask his personal experiences through this journey, um,
Can
and
I ask
especially
a question?
challenges as an organization. Yes, please. Yes, who was that? Go ahead.
Can you hear me, William?
Yes, Abla. How are
Okay,
you?
okay.
Yes.
Shamaran, you mentioned during the presentation that you offer support for families.
Yep.
Can I know what kind of support? Is it mental health support or economic support? Thank you.
Okay.
Shamrun, you want
Yep.
to
Thank you,
answer?
Abla, for your wonderful question. Actually, the type of support we provided, it's actually again customized and tailor-made to meet the different needs of the family. So before we believe that we have to build their strength, and we have to first use the existing resource. So before we provide any support, we first identify what the support need, and then we conduct the assessment of the community. For example, with the commune service, do they have any existing commune budget that can allocate to support this family? If not, then we start mapping the NGO partner who are working in the same geographical area, and then we link the family to them. But in some cases, the commune do not have the budget, and also there was no other organization. So what we offer, our support can range from, helping them, identify income generation activity, or starting like small business or vocational training. But for some family also, they have, like a mental health problem themselves, and they are the primary caregiver of this child. So we first, for us, we provide them like a capacity building around helping them learn to, cope with the problems, learning to identify, prioritize the problem, seeking a solution. But also, if the situation is serious beyond our capacity, we make referral to the clinical psychologist or psychiatrist. I hope I answer your question.
Yes, thank you so much. Thank you so much.
Thanks, Abla. We have Pierre. Please, Pierre, you have any question? Pierre speaks French, but we have interpretation. Pierre, please go on. Pierre. And then, okay, there he is. Yes.
Oui, bonjour. Oui,
Bonjour.
bonjour. Bonjour. Oui, merci
Bonjour.
pour cette présentation. Pour dire qu'aussi c'est le sujet qui nous rassemble ce matin est pour nous très important dans le travail que nous faisons parce que tout simplement les gens, les communautés sont confrontés, les enfants et les jeunes surtout sont confrontés à ce problème dans les quartiers, dans les villages où nous sommes. Et on remarque qu'il n'y a pas assez de services. Nous, dans nos pays, nous n'avons pas beaucoup de psychologues, nous n'avons pas beaucoup de psychiatres. Alors, face à ce problème, c'est un peu ma question, c'est par rapport à dans cette approche qui nous a été présentée, comment les communautés se situent dans cette approche. Parce qu'on sait que nous, en tant qu'organisation, ou bien l'État avec ses structures, leur réponse est insuffisante par rapport à la demande. Et comment on intègre justement la communauté dans cette approche. Je pense que Thierman l'a dit, on prend par exemple, voilà, un fait qui est là, un enfant qui perd ses parents. Est-ce que la communauté est sensibilisée, formée justement pour accompagner cet enfant qui vient de perdre un parent ou des parents? Comment la communauté, quel rôle joue la communauté dans la prise en charge? Et ma seconde question, c'est concernant les enfants qui sont pris en charge. Euh, Est-ce qu'il y a un système qui permet justement de faire des référencements, par exemple vers des structures étatiques ou vers des hôpitaux, quand on sait que justement on ne peut plus satisfaire le besoin de son enfant parce que tout simplement on peut parler de maladie mentale et que peut-être qu'il a besoin d'un spécialiste pour être suivi, accompagné. Est-ce qu'il y a un schéma qui est là déjà avec la collaboration de plusieurs structures qui permet justement de faire ce référencement? Donc voici mes deux questions en félicitant une fois de plus le travail qui nous a été présenté, mais surtout le travail sur le terrain. Merci.
Thank you, Pierre, for your wonderful question, but also your comments on that. So in terms of the question, in terms of, I think there is also a question in the chat that focusing on the community capacity building or strengthening. So this is another level of work at First Step. To be honest, First Step at the moment is also a member of a number of national working group. So I'm the representative of First Step as a technical member for developing training curriculum for the social service workforce. So we have already developed many of the training curriculum and roll out to the community levels. But at the moment, we just focus on mostly on the government duty bearer and to ensure that they have the capacity to respond initially to the needs of the children and improving their service delivery. And the other aspect of the community, at First Step, we do a lot of, like what we call the community key people empowerment. We deliver training, coaching sessions on, different aspect, focusing on prevention, child protection, online sexual exploitation, and then how they can provide initial support to children in need. As you mentioned, that First Step cannot do this work alone, and there is this much that First Step can do, and we need larger workforce to be able to respond this throughout the country. For the child referral system or child center approach, at the moment in Cambodia, we are still trying to establish this. So as we are not very well established yet, but we still do this coordination through, both NGO and government networks at the subnational and national level. We can see this has been improving, and the Ministry of Social Affairs has been taking on mostly the role of the coordination, but also in Cambodia, we have this called Commune Committee for Women and Children. They are based in commune, district, and provincial level, that they mostly do the coordination to ensure that children receive the support they need. And they are the center of, or they hold a map of all, both public and civil society services. So I hope I answer to your question. And I see a few other questions in the chat.
Yeah, thanks, Shamron. We have 2 or 3 more. We have Mohsin Sheikh. Can you please talk about your question and what you want to share? I hope I'm pronouncing your name correct. Mohsin Sheikh. I think your question was about do you have any established staff care mechanisms for your
Mm.
team integrated as well?
Hello.
That was one question. Yes, please go ahead.
Hi, good evening. This is Mohsen from India. So, right now we are just working with the caregiver. So, the caregiver's term we are using the child who left from the childcare institution after the age of 18. So, I am also a caregiver in our organization. All the caregivers we are working. So, my question is the stigma doesn't and when we young people leave the care, so it's often follow them to the school, job, relationship, especially we call the relationship in different sectors. So how does FSC community facilitate or the capacity building work extended beyond the immediate care period to reduce that long-term stigma? So
Mhm.
if you can say something.
Yeah. That is a very interesting question. Unfortunately, at first step, we do not focus on caregiver. We have a partner organization, so-called MHPSS, that they focus on that. And the practice also has been discussed and built among the NGO network. So in Cambodia, we also so I'm talking on their behalf. I'm not very I don't have very comprehensive information about that, but I understand that the framework is very in depth and very impactful because for example, like after they leave care, the organization they start developing the caregiver network. So before they leave, the organization they will conduct in-depth assessment of the uh, risk and then identify like strengths of the community where they are going to live, and they also have if they go back to their family, the organization will make the family unification, because often it's very hard for family to have close relationship after the children live in residential care for a long time, and often there are a lot of challenges both for the family and for the caregiver themselves. And later on, the organization actually start the caregiver network where they provide ongoing training, but then this caregiver become the peer support for other caregiver. So that's the information as much as I can provide based on my knowledge. And for Jana, your question about staff care, it's very important question. In terms of as an organization, which we are aware of trauma and informed care. We also understand that our staff can be affected by the story of the child, the complexity of the experience of the child and the family they are working with, and sometimes their own personal experience can be also triggered. So at first step, we provide regular so-called the supervision. I'm not sure if you are familiar with that, but those who are working in social work and mental health, you may understand that. So in the supervision session, we can discuss the support need of the staff, identify capacity building needs, and also at time we may discuss about their caseload. We need that may need adjustment and all that. Beyond that, we have regular so-called team building, where staff can spend time joining the team building activity, and then they have reflection on that, and it's a time for them to express themselves. And we found that many many staff so far, they learn that this has been very helpful to prevent burnout, to prevent exhaustion in their work. And so far, some of the local NGO and international NGO in Cambodia, they have learned from first step, and they also replicated and build that into their own policy and system. And from time to time, we also ensure that staff have the time to review and reflect on the achievement that they have so far. So we have like every 6 months, we have 2 days off work. So we sit together and reflect on what we have achieved, how our work impact and change the life of children and communities. And that's how they also empower or feel, like what we say in Cambodia, like we recharge our battery. And also we learn about the challenge that has been dealt with or addressed, and then also the challenge that has not been addressed that we need proper discussion, so that the team have the opportunity to voice and to receive the support they need. So this is what we offer. And from time to time, if staff need external supervision, sometimes they don't want to discuss this with their supervisor in the organization, they are free to go to receive supervision from external service provider that we contract with, and they can hand us a bill, no question asked. So this is the staff care that we provide, but then also we have challenges in terms of funding. And often donors don't like it. And I always advocate that, and I always make this strong argument that, I guarantee if we provide this, staff are more effective. They also, when they are healthier, the organization is healthier, and then, we achieve much more. I hope this
Thank you, Shamron. Yeah, it looks like there is a message to say thank you for your response. I have two questions. One is if you want to, someone else in the group want to support Moshin's questions, we'll come back to that. If you have any experiences and models to support aftercare young people leaving care and continuing getting that support. But before that, there was one thing, because it's very specific to First Step Cambodia. They have worked with social workforce through the social work institutions very much. They've advocated for good practices both in child protection, child rights, and now in trauma-informed care. Do you want to share, because it is not just capacity building of their own staff, for the sake of being sustainable, I think they've worked quite a bit in influencing the social workforce in Cambodia. Do you want to share a thought on that, Shamron?
Yeah, thank you, William. I actually come from a background myself. I have been a practitioner for many years. I was not certified. I did not have any social work or psychology certificate. And at one point in my life, I decided to pursue my degree at the Royal University of Phnom Penh for the master. And that's where I learned that actually the training we offer have been very valuable, but there was lack of theoretical framework to back our practice. And based on my experience, my years of experience developing training curriculum and so on, I see that the two can, actually fit well together. So inspired by that, I decided to, actually discuss with the team and the board that we have to contribute to this. So then we start joining the working group at the Ministry of Social Affairs to support the National Institute of Social Affairs to develop their training curriculum. Alongside, I also work in partnership with Lukrusa organization to develop social practice training curriculum, because we understand there are many social workers, practitioners on the ground that they have not been trained. Their practice is passing on from one to another. So often that also make it hard for them to feel confident to engage with children, to engage with especially family. They struggle, and based on that learning, we understand that with theoretical framework, they can feel more confident because they have lots of experience. So what we try to do is, linking theory and practice together. So when we develop training curriculum, the consultant often provide a theoretical framework that, we often don't understand. And then when we talk about the practical frame, like experience on the ground, they often struggle to really link, link. So that's where our effort, actually bringing this together, which make the training curriculum in Cambodia so far is more contextualized compared to the past, 5 to 10 years. And there are more also social service workforce at the moment receive, comprehensive training. So, for example, like when I track down the data, there are more than, just in First Step Cambodia ourselves, we train more than 1,000 social service workforce. And each actually attend multiple training courses that actually recognized also by the Ministry of Social Affairs. That's why we are now become the national member of the working group.
Thank you, Shamron. And one quick question which we earlier thought of discussing. You speak of this model that it is direct support approach, combination of ecological approach, in the sense that when you talk about ecological approach, it is you're working at 4 or 5 different levels, individual, that is for the direct recovery, resilience, life skills, etc. And then you're building relationships that involves families, caregivers, peers, trusted adults. And then you have community, a third layer, building protected communities, again through referrals, awareness, and partnerships, etc. And the last one, institutional and legal framework, that collaborating with government and service providers. This seems to be quite a large ecosystem. And how do you manage, and what are the challenges in a way? It looks like I'm not just referring to resources and staff, but generally, when you're working simultaneously like this, what are the challenges, and even like what are your results? Probably, if I could ask, how, like, sort of the impact of your work, Shamron.
Yeah, thank you for the question. The work that we have done has been, quite challenging. As like our staff require, like different skill sets. In one purpose, in one staff member, they have to possess different that, and our challenge is around, how do we get the resources for staff capacity building? You may know that, as the organization rely on the, restricted funding, often donor don't really provide any funding for staff capacity building. Even like some donor checking our, require us to fill in timesheets. So it's very hard for us to have space to build the capacity of the staff. And again, I want to repeat myself about the staff care. Often don't want to fund that. So we have to do a lot of advocacy work. We have to also be very smart in terms of the way we structure our budget and structure our time, something like that. But also to engage in that, live beside the skill set, the capacity of the staff. How do we convince the community? How do we convince the government to see the importance of their role in this work? So it takes a lot of time and effort, and we play different approaches to that. For example, with the national level, sometimes we use the soft approach, taking time, sitting at lunch or coffee, discussing different, issues and some ideas that we have, and testing what they think about it. And sometimes we also use hard approach, critics that, this is not working, and, we need you to, change this and that. And again, it's a lot of time that we spend not really working hours, during lunch, during, coffee break and so on, that, we have to invest. And the other challenge is around, sometimes we spend 5 years building relationship with the focal person at the relevant ministry, relevant province.
Mm.
But then, after the election, they change to another department or another places, and we have to rebuild this. But then we understand the importance of this relationship building, resource prioritization. And in other cases, like I mentioned, some community, there is a lack of support system and resources, while many there exist. And often that is going to be our priority and our investment in supporting the children and family. We also have experienced that sometimes there are complaints. For example, our work with children who display problematic and harmful sexual behavior. They often say they are the perpetrator. Why are you working with them? We are supposed to be supporting the survivors. We have to help them understand the needs and understand that children has the right to development, and with the right support, they can change. And this will also prevent further investment in the future. So these are
Thank you,
some
Shamar.
challenges that we face.
Yeah, thank you. We have just 2 minutes or so. Maybe this question is very relevant. You can answer in short because it's really touches again the trauma-informed care and principles. So if you're doing all this, the question is, what type of child protection planning look like when there's no stable family or trusted adult to strengthen a relationship with? So what does FSC's child protection planning look like when there's no stable family or trusted adult to strengthen a relationship with?
Thank you. I mentioned that first step is not alone, and we don't provide all the services ourselves. So we have partner like Children in Family, like Loprusay, that they actually offer the, emergency foster care, and other they provide longer, foster care. So depending on the need of the child. For example, like the one of the girl who actually display problematic and harmful sexual behavior, that at the beginning she was placed in different residential care center, and she was displaced from one to moved from one to another places because of her behavior. So actually, when we first met the girl, she was in one of the residential care, and we learned that it's not helpful. There was no way that the girl will, like be able to improve or change her behavior living in that environment. Because foster care, the caregiver has to take care of so many children, they cannot focus their support. So we work with our partner organization to, ensure that she receive the care from a proper family. So she was then later moved to this, or placed in this foster care family that firstly was very challenging. But, after our, intensive works and long term, then she changed, and then the relationship with the foster care father improved, because with the lack of understanding, often, like why a girl does what she does, she was supposed to be, gentle, calm, not really showing behavior and so on. With the lack of understanding of the experience she has, the father actually struggle, and sometimes, use violence against her, and it doesn't help with the behavior, it just worsen. So with the understanding and making a from the father perspective, and then help the girl understand her own behavior and learn, non-violent communication and so on, the relationship has improved, and then the behavior also change.
Thank you very much. There is one more question, but we are not going to take it because of time. And please, Mohsin, put that question using the community of practice. That's a good opportunity, so others also will see that. I want to thank you, Shamron. In the beginning, actually, I was looking because two of us were sharing the computer screen. I was looking for to say more about you. I couldn't find it, but as we close, as I thank you, I just want to say, knowing you, how hardworking you and your organization is, and especially wanting to uh, practice like using like the best practices. So Shamron, his leadership of First Step Cambodia began during his role as an overall project coordinator of the First Step project. As part of there was another organization, and then they sort of joined together. And since 2012, Shamron served as the executive director. Shamron has earned undergraduate degree in Science of Life from Grassroots Development Institute in Malaysia, and then an undergraduate degree in Human Resource Management from Cambodian Mekong University, and a graduate degree in Social Work from the Royal University of Phnom Penh. Shamron has contributed to numerous national and international alliances of civil society organizations working together to improve the lives of vulnerable children and families, sharing their expertise and initiating new research projects, both independent and collaborative. Thank you so much, Shamron, for sharing, and thank you all those who participated. Please log into Changemakers and also the mental health and well-being community of practice. Thank you, Rijita and Dee, for your technical support and organizing for us. Have a nice evening or afternoon or the rest of the day, all of you. Thank you.